Hello, everyone. At the outset, let me thank Dr. Unikrishnan sir for giving me this opportunity to speak on the topic which is very close to my heart, a very much needed preventive area in the management of diabetes. So today the topic given to me is FibroScan for NAFLD detection in a diabetes clinic. Whenever we are treating diabetic patients, patients with diabetes, we always follow our Bible, that is ADA recommendation. And to my surprise, actually, I was just going through the literature, and in ADA 2019 recommendation, it is already recommended that patients with type 2 diabetes mellitus with elevated plasma ALT levels or steatosis on liver ultrasound, they have to be evaluated for NASH and liver fibrosis. This is very important point. The rationale for screening such patients, we know that is based on increasing evidence that NASH with advanced fibrosis is associated with liver-related and extrahepatic morbidity, mortality like cardiac manifestations and liver cell carcinoma. Now let's look at the numbers. Unless we read the number, we don't know how much is the problem. So this is the global prevalence of NAFLD. If we look at Asian area closely, Asia has incidence prevalence of NAFLD around 27 to as high as 30%. So the burden is really huge. Talking about the interplay of obesity, metabolic syndrome, insulin resistance, type 2 diabetes, dyslipidemia with respect to NASH, when patients already come to us for the first visit, patient is already in the state. I don't think we get any patient who has healthy liver at the outset when the patient is diagnosed. It is always in the stage of inflammatory stage, NASH or maybe NAFL. Very rarely we see patients at diagnosis have cirrhosis, but we need to be very, very proactive. Now, today I'm not going to go in the details of NASH pathophysiology, but today the topic is FibroScan. So I'll be directly talking about complex multi-hit process, which kind of speeds, accelerates process of hepatic steatosis to NASH and fibrosis. To our experience and from the literature, it's not just obesity, insulin resistance, diabetes, or metabolic syndrome, but there are many other factors like hypertension. Uncontrolled hypertension accelerates this progression. Genetic factors, postmenopausal status, older age, microbiota, many factors are involved. And what do patients with NASH die from? This is a very good study. 12 years follow-up, 619 biopsy-confirmed NAFLD patients were monitored for 12 years. And the major cause of mortality, almost 38% was cardiovascular diseases. Other causes, other cancers, non-liver cancers was 18%, and cirrhosis complications or probably SCC was very, very low. So NAFLD and mortality, CV is always the main cause. Liver disease only third cause of mortality, and multi-morbidity patient-centric care model is very, very required. This disease is invisible to GPs. GPs, family physicians are dwarfed by chronic diseases, frailty, mental health, reproductive health, child health. So we really need to be very, very proactive to tackle this problem. We need to have referral pathways. We need to have a streamlined management system where, there is how to select patients for referral is very, very important. That needs to be taught on the first primary care health worker. Non-invasive fibrosis assessment has to be applied for each and every type 2 diabetic patient. How to design a referral pathway? You educate, and finally, education about evaluation and primary prevention is very important. Now, these are few NASH registries, and they have done fantastic job, and we all hope to see Indian flag amongst these registries very soon. Now, how do we evaluate patients? First, we rule out ethyl alcohol consumption and negative chronic liver disease screening, and maybe on ultrasound we see there is fatty liver. Very simple FibroScan score is available. I'm going to go in detail in next few slides. It's a very simple test. This test should be done for each and every patient, and if the FibroScan score is intermediate, that is between 1.3 and 3.25. These are the patients who are going to require some radiological investigation and ideally elastography, that is FibroScan, to see whether the patient has developed any cirrhosis and how much is steatosis present at present. Now, these are diagnostic modalities for NAFLD. Recommended modalities USG. Then we have, liver panel enzymes. We have liver biopsy, serum biomarkers, and last but not the least, FibroScan. FibroScan is quick, easy, and convenient. It is non-invasive. Complication risk is almost zero. And sensitivity specificity is very good sensitivity 80 to 90% for detecting fibrosis, and it correlates the degree of inflammation better than any serum fibrosis markers in cirrhosis. When we are talking about diagnostic modalities, first thing is in outpatient clinic, in our OPD clinic, FIB4 requires only 4 parameters, age of the patient, SGOT, SGPT, that is ALT, AST, and platelets. NAFLD has got few more additional parameters, but FIB4 is the most convenient score system we can use in outpatient practice. And this is a simple formula which is available online. You just have to enter age, AST, ALT levels, and platelets. And this patient, if you see 67-year-old patient, this is just an example of one patient we entered values. And if you look at his SGOT, SGPT levels are not badly deranged. But look at the FIB score. FIB score is 2.1, and on FibroScan, patient was already in F2, F3 level of fibrosis. So this is a very, very important calculator score or preventive score, I would say, for fibrosis. Using this score, I'm just sharing one small paper which we presented at Paris NASH meeting. Around more than 400 women were evaluated. They were basically retrospectively analyzed. And our FIB score was calculated. History of alcoholism or chronic liver disease was excluded. These patients were excluded. And the FIB score between less than 1.4 is normal. Between 1.4 to 2.6, we had around 58 women. 2.6 to 3.2 were 5 women. And more than 3.2 FIB score, patient already had developed fibrosis. The number of women out of 438 were 7. And mind you, all these women were asymptomatic. They did not have any idea. They did not have any symptoms as well. Then eventually lifestyle modification, pharmacotherapy was started. These patients were further evaluated by FibroScan, and the monitoring is going on. And in the last 1 or 2 years, we are getting excellent result, reduction in FIB score and reduction in the stiffness index as well. Liver biopsy was the standard for seeing histology in NASH patients, but with the pandemic of NASH and fibrosis, I don't think getting each and every patient biopsied is a very, very good option. So these are a few, I would say the liver biopsy is not a viable approach in routine practice. It is invasive, painful, sampling variability, observer variability, and we have limited workforce capacity in our outpatient clinics. So 1 in 1,000 patient can have severe bleed, and 1 in 10,000 patient have mortality risk. So 100 million individuals were to be biopsied, then almost 1 lakh life-threatening bleed and 10,000 deaths can occur. So this is the kind of risk liver biopsy can pose for any simple NASH patient, NAFLD patient. So what do we do now? How do we go about it? Now we have this transient elastography, which is FibroScan, today's topic. Is a non-invasive method of assessing liver fibrosis which can be performed at bedside or on outpatient basis. It is basically vibration-controlled transient elastography. Now let's see how it works. This uses pulse echo ultrasound technique to quantify speed of mechanically induced shear wave within liver tissue. Now, liver stiffness has been well validated to correlate with severity of fibrosis. At the same time, hepatic steatosis can also be, so along with stiffness, steatosis can also be quantified by this machine. There is ultrasonic attenuation of echo wave, and which basically is called controlled attenuation parameters. So in simple word, we come to know about stiffness and we come to know about the steatosis as well. So fibrosis and steatosis, both the things can be measured with this machine. Now, how does it work? I just mentioned that, but the more the fibrosis, this line is very important. If the liver has more fibrosis, this tissue is going to be stiffer, faster shear wave progression, and higher kilopascal value. So very important that if fibrosis has developed, the values are going to be more because stiff tissue will allow shear wave to progress very, very fast. This is a basic principle of this machine. Now, this measures liver stiffness in a volume which approximately, coincides 4 centimeter in length and 1 centimeter diameter. That means it is 100 times bigger than a biopsy sample, and it should be more representative of, definitely, more representative of liver parenchyma. And the skin, it is below 25 to 65 millimeter underneath the skin surface. But if you compare with biopsy sample, it definitely gives a bigger picture. It has been validated in a NAFLD and useful tool for rapid non-invasive assessment of liver fibrosis and determining need for a biopsy. Now, how do we perform this test? Very simple. It takes just 5 to 7 minutes, not more than that. It is a bedside test. Patient can be non-fasting, but at least 2 hours fasting is advisable. Patient will lie in supine position. I'll just show you the picture. Patient is lying in the supine position, legs towards the left side of the bed, and right arm has to be behind the head. Intercostal areas are measured. Xiphoid appendix go parallel, go in the mid-axillary line, and the probe is put in the intercostal spaces. The zone has to be free of tight muscles. Arm should be bent. So this is the simple position. Once the measurement area has been located, operator presses it is exactly the same area where the liver biopsy needle punctures. The puncture is taken. So once the measurement area has been located, operator presses the button on the probe to start acquisition. Software determines whether each measurement is successful or not. If the value is not successful, it is not recorded. If it is falsely high or low, it is not recorded, and results are expressed in kilopascals, and it always corresponds to the median of 10 validated measurements. So take 10 validated measurements are taken, and only median of these measurements is taken. So accuracy is 80 to 90%. This is how the report card looks like. Down, if you see just below chronic cholecystic diseases, the kilopascal liver stiffness from 1 to 75 is too much, but 1 to 23 is given. We haven't seen anything beyond 20 or 25. F1 to F2, F3 to F4. Now the stiffness zones are also, the range is different for each liver disease. If you see for alcohol, the stiffness measurement starts at some different level. For NAFLD, it is different. So I'm just going to show you one card of NAFLD. This patient had stiffness of 11. Now, 11 stiffness directly coincides to F3 level. F3 means patient has already developed fibrosis, lifestyle modification, pharmacotherapy, and patient needs to be referred to the hepatologist. Now, this is a FibroScan algorithm. High-risk patients or undiagnosed patient or treatment going on for NAFLD patient, FibroScan should be done for these patients. If patient is in early NASH, liver enzymes are normal or elevated, the follow-up should be maybe, they say 5 to 6 years, but I think yearly follow-up is must. If it is F2 level, there is indeterminate NASH. There can be liver biopsy if there is high index of suspicion of any other causes, or just lifestyle modification and pharmacotherapy can be started. Anything above F3 fibrosis, all the levels, the kilopascals are given on the report card when the report is given. So anything more than F3, hepatologist reference, and eventually lifestyle modification and pharmacotherapy is started for these patients. Now, this is a clinical study in which 246 NAFLD patients with FibroScan and liver biopsy were studied. FibroScan seems to have a good accuracy to distinguish NASH patients into NAFLD population. And FibroScan performs significantly better than all studied blood markers or any fibrosis score in F3 and F4 level. So when fibrosis sets in more than these FIB score or NAFLD score, FibroScan has a better prediction value. Now, where should we? There are some situations where we should be careful. It shouldn't be used in pregnant patients. And a NASH patient, NAFLD patient who has coexisting acute hepatitis, hepatic congestion, hepatic amyloidosis, it can be falsely elevated. So we have to be careful in such situations. Now, this is how the screen looks like. It's a very simple procedure, real-time overview, final results at one glance, and smart implementation. Now, I'll show you how. First, we see ultrasound signal. Then, without pointer, it is difficult, but elastogram is seen. List of individual measurement. We just understood that 10 validated measurements are taken, and in the box below, 224 is basically value of steatosis, which we are not very much interested in, but we need to know the stiffness value. The stiffness value is 6.3 kilopascal. That means it is normal. And probe selection is also very important in obese patient to have false high or false low reading. We need to use Excel probe. Now, these are the advantages: reproducible and independent of operator. It explores volume of liver parenchyma, which is almost 100 times larger than biopsy specimen. It can be carried out on OPD basis, and patients do not experience any pain. I just mentioned it's rapid, just maybe 5 to 7 minutes, non-invasive, patient-friendly, and last but not the least, it is very suitable for periodic monitoring, and progression of NASH or reversal of NASH has to be monitored. Only FIB score value monitoring is not going to be helpful. Many times enzymes are normal, but fibrosis can worsen. So you have to have periodic monitoring, and with FibroScan, it becomes very, very convenient. So this is how we do risk-based stratification. I'm just going to read the values of FibroScan. If you see on the third level, below non-invasive risk stratification, second last line, if FibroScan is less than 5 kilopascals, it is, there is no evidence of NASH. If FibroScan is between, the stiffness value is between 6 to 12, we need to immediately, this patient falls in intermediate risk profile, steatohepatitis, and if a patient is already at stage 2 or 3 fibrosis. And if your stiffness level is more than 12 kilopascal, that is a pink box I'm talking about. If stiffness level is more than 12, then patient goes to fibrosis, stage 3 and 4, high risk profile, direct hepatologist reference, and further treatment will be, and further evaluation of complications is initiated. I'm going to just discuss few of the patients. All these patients were asymptomatic patients. They were routinely subjected to FIB-4 score as a protocol. And this patient, the first patient is a 61-year-old female with past history of RCC. 2019, pre-pandemic, when patient had her FIB-4 score was 0.65. In 2021, during her routine evaluation, FIB-4 score was found to be 7.5, which was very surprising. And we did FibroScan for this patient. The FibroScan showed very high stiffness, which was in favor of, NASH, NAFLD, leading to fibrosis. This patient was referred to hepatologist. Treatment was initiated. Patient had already developed some varices, but this patient was referred to hepatologist because of FIB score, early reference, and patient had not developed any complication. In 2022, FIB-4 score came down from 7.5 to 4, and the stiffness value also came down from 21 to 8.3. Sorry, this patient follow-up FibroScan is still not done. FIB-4 score settled from 7. This patient had already was in progressive fibrosis, and from 7.5, the score has now advanced to 8.3. So probably during pandemic, her LFTs were not done, and we could have picked up this patient maybe in 2020 with lower score. But unfortunately, this patient's fibrosis is progressing in spite of treatment given to her. The patient is clinically stable. This is a very interesting case. 49-year-old female patient, A1C was around 6.0, weight around 69 kg, a corporate woman. FIB-4 score in December 2019, pre-pandemic, was around 2.09. FibroScan done in January 2020, just before pandemic started, was 8.8, slightly on the higher side. PIO, SGLT2, lifestyle modification started. This patient was during online working. She managed to lose around 7 kg. She concentrated on her lifestyle modification, diet particularly. December 2021, excellent result. FIB score came down from 2.09 to 1.8, and the stiffness also settled from 8.8 to 6.8. So this is a patient which gave very good results with lifestyle modification. Obviously, we have to give credit to the pharmacotherapy as well, but with weight loss, the things have settled down. Now, this patient, she is 69-year-old patient, type 2 diabetic. In 2019 September, her weight was around 53, not an obese patient, and FIB-4 score was 2.1, and FibroScan showed very high value, 23. Immediately, lifestyle modification was started, PIO was started, and UDA was started. She was followed up continuously, and in 2022, when her repeat scan was done, repeat scan showed stiffness reduction 16.9. Her FIB score also settled from 2.1 to 1.1, though there was no change in weight. Probably she had put on weight from 53 to 56 kg. Probably she was on 15 milligram of pioglitazone. So PIO made her put on weight. But I feel the basic pathology of insulin resistance, which is for type 2 diabetes and for NASH as well, was corrected with her modified lifestyle and pioglitazone. Patient 4, 61-year-old female, she has past history of breast cancer. During routine examination, FIB score was found 1.8. Her FibroScan was done. Stiffness level was very high, 15. Treatment was initiated. Patient has not done anything much, but there is no weight loss. Probably due to pharmacotherapy, her FIB score improved from 1.8 to 1.3, but there was not much significant change on the stiffness level on FibroScan. So it's a very interesting patient, pre-diabetic male patient. On routine corporate investigation, he came to me with ultrasound grade 3 fatty liver, non-alcoholic patient. FIB-4 score was around 1.8. We warned him with respect to that time. FibroScan was not done for this patient, and this patient, actually I'm sharing data, the FibroScan is not done for this patient, but this is a case where everything reversed just with FIB-4 score. There was a weight reduction over the period of year from almost 10 to 14, 10 kgs weight reduction, 10 to 14 kgs weight reduction. BMI dropped from 33 to 27. Metabolic age dropped from 80 to 72, which actually matched his actual age, biological age. And A1C dropped from 5.9 to 5.5. So just by looking at FIB score, this patient, when warned for further liver consequences, he took right measures and everything reversed back. We are using FibroScan for patients whose FIB score is on the higher side. Okay, now these are the number of patients, around 42 patients. 42 patients were evaluated for median stiffness. Median stiffness by FibroScan. Now this is the population of the patient where FIB score was already high. We didn't know whether the patient has fibrosis or no. But to our surprise, with borderline FIB score also, 45% of the patients on FibroScan showed stiffness, F2 to F4 level. And these are the patients who are now initiated on pharmacotherapy, lifestyle modification, and we are on follow-up FibroScan after 6 months or 8 months, we are getting good results. So in conclusion, conventional approach will not help. We need to treat the root cause. Root is a system. It is not just one single root. We need to develop a multiple optional solutions system for detection and cure. Patients, they just don't die from liver disease in NASH. Directly acting antifibrotic therapy is not likely to work well when used alone. Treating the cause of a problem makes sense and it will actually work. So this is my, this slide is self-explanatory that whenever we are treating any problem, be it a heart problem, liver problem, any problem in diabetic patient, early detection is a key to unlock any problem. Thank you so much.